go to share screen. And this is for the GI tract. And again, just double check that you can see the screen.
Yes, Prof, we can see your screen.
Thank you very much. Good, good, good. Okay. So imaging the GI tract. So the GI tract is actually, gastroenterologists would try to convince you, is the most complex organ in the body. It is unidirectional. You can't put food in the wrong end and get nutrition from it. It only works in one direction. It has a very complex immune system. And one of the things about COVID that's very interesting is that what we don't know, for example, is if you give people immunization, they may not get clinical COVID, but they may still be able to shed virus from their mouth because it has a different immune system than the rest of their body. And certainly that happens with the common cold. And those of you who know about influenza will know that in children, the vaccine is given primarily through nasal spray to ensure that they're able to immunize the mouth and face area, because this is the area where children touch and they spread the virus. Also, a gastroenterologist will be very pleased to tell you that there are more neurons in the gut than in the brain. Now, that may not come as a surprise to many people, because there's the famous adage that the way to a man's heart is through his stomach, and that might be relating to the number of neurons, the relation of neurons between stomach and brain. So what can go wrong? Well, anything that moves can move too fast, it can move too slow or not move at all. We can have congenital problems such as it doesn't exist, atresia, or we can have leaks, fistulae, or we can have ectopic tissue. I think particularly of gastric ectopic tissue. And finally, we can have malabsorption as well. So what else can go wrong? It can get infected and get inflamed, so it can leak, it can bleed. Sorry?
Thank you.
Okay. You can get trauma to it, and you can get tumors, either benign or malignant. So why functional imaging? Well, functional imaging is useful for an organ which is functional. So nuclear medicine offers quantifiable and reproducible results. Other radiological techniques involve multiple imaging, and for example, if you're using barium, you need to take lots of pictures, which is a high radiation dose. To be honest, these techniques are often very simple, but they're often underused. So we're going to start really at the top of the GI tract and work our way down. We're not going to include the renal tract or lungs, though they are embryologically part of the gut, because we've done those already. So there, that's a very nice meal. I'm not quite sure what it is. There seems to be a bit of bread, some rice, maybe some yogurt or something. So let's see what happens. Let's start at the top with salivary glands. These can be inflamed due to sarcoid, or they can have duct obstruction due to tumor or stone. And the two things we can do, if you're looking for sarcoid, we can do gallium or possibly FDG PET, but also we can do salivary scintigraphy. So this is a different patient to the one I showed you previously. This is another sarcoid patient, but with very intensely active salivary gland, lacrimal glands here. So this one looks much more like a panda, I think, because I've turned the black and white the other way around. Salivary gland scintigraphy, particularly useful in patients who have xerostoma, and many of you doing PSMA therapies now may be doing a lot more salivary gland scintigraphy because of that. People who've got pain when they take a Cylogob, like lemon juice, that may be due to a stone or may just be functional. You can get tumors as well, and also you can get inflammation. You can get, which is effectively what we're getting when we give PSMA, like actinium PSMA, can result in inflammation. So it's a very simple test. We can use up to 700 megabecquerels per technetate, do an anterior image, dynamic 1-second frames, and then some 10-second frames. And we look at uptake into the glands and how they clear. Now, if they're not clearing very well, we then give what's called a Cylogob. That can be lemon juice, or it can be a lemon, a sort of very acidy lemon type sweet. They can suck, obviously not if they're diabetic, but never mind. And you draw regions of interest over the submandibular and parotid glands, and you do time activity curves. So this is a sort of rough guide to what you can see. There's difference in flow, uptake, and washout. So in tumor, the uptake's reduced because the tumor blocks destroys the tissue, but flow and washout isn't affected. A cyst effectively destroys the tissue, so you get it reduced all the way through. An inflammatory condition called Sjögren's, which is related to scleroderma, reduces flow and uptake, but washout is normal. Sarcoid, interestingly, tends to have an increased washout, and we don't understand why. And stone, obviously, if it's blocked, it's just like a kidney, it has reduced uptake and reduced washout. Radiation inflammation of the salivary glands is a little bit like Sjögren's. So here we have a normal study. So the regions of interest have been drawn over the parotids and the submandibular glands. So there's 4 curves. They increase until the patient, it takes about 15 minutes. Then the patient's given some lemon juice and it just empties quickly. And on this side, there is a left-sided tumor. So uptake is much reduced on the left side because there's no working salivary gland because it's all been replaced by cancer. So moving down, we get to the esophagus. That's the tube into the stomach. The primary thing that really we get here is either tumor or inflammatory conditions that result in changes in the way that it flows, or a fistula. So esophageal cancer normally occurs at the lower end. It's locally invasive. It often presents with dysphagia, and the risk factors are repeated hot drinks, alcohol, smoking. And if it's caught early enough, it can be cured surgically or by radical chemoradiation. And we use FDG to PET to stage it. And we're particularly looking to try to avoid malignant disease, but we also want to try and see how many nodes are involved. So N1 disease is 2 nodes or less. N2 is 3 to 6 nodes. Now the nodes can be anywhere between the supraclavicular fossa and the gastric nodes and celiac nodes in the stomach. But if there's more than 6 nodes, then it's considered not operable, though they may still have chemotherapy. So here we have an N1 stage tumor. So you can see at the GOJ junction, there is the tumor, that's the heart, and there's a little gastric node there. When you're looking at an FDG PET of an esophageal cancer, it's often very nice to look at the sagittal view, because it gives you a very nice picture of the extent of the tumor, how long, because the length of the involvement of the esophagus will either affect the chemoradiation field or the surgical operation. The esophageal scintigraphy looks at transit. We can use liquids and solids, and liquids is impaired in neurological disease, solids in inflammation or tumor. And the solution then may be to either use liquids or solids, or use a semi-solid, like baby food is a very good semi-solid, which is easy to label and comes in a nice little handy pot most of the time. So let's say you can cook some apple or just use some pure baby food, add 20 megabecquerels of technetium colloid, give it a mix, put a small volume on of food on the patient's, on a plastic spoon in the patient's mouth, ask them to hold the food in the mouth, start the gamma camera and ask them to swallow and take 31-second frames. The patient then washes the activity out their mouth with some water, and you can repeat this at least 3 times, and it's best to do it erect and supine. But when you're imaging, remember you don't want to get the spine in the way, so bring the camera around and use a 30-degree RPO or LPO position. Now, you need to try and demonstrate this data in a meaningful way. You can look at the dynamic imaging and the time activity curves, but they can be quite difficult to read So people invented this thing called the compressed view. So what they do is they have multiple images, and this is, let's say, a bolus of food going down the esophagus, and they compress it into a single image like this. So you very easily can see the way that the bolus goes down. And this is one such case. So here we have activity going into the stomach, then refluxes, stomach, refluxes, stomach, refluxes, stomach, refluxes, stomach. So this is a nice way that you can see it. And that represents around about 5 minutes worth of acquisition. This patient is another one where we have a little bit of reflux, but not so much. And you can see also you've got time activity curves, which will help you. So what you've got is stuff going down into the stomach, one reflux, down, second reflux, down, and then it stays down. So this is a very good way to report these studies. Now, you get more reflux when the patient's lying down, which is why we do it lying down and standing up. Well, that brings us nicely into the stomach. So the main studies here are gastric emptying. And we're normally looking for poor gastric emptying due to dysmotility. Again, we can look at liquids or solids or both. Now, for PET-CT, the staging is very similar to CA esophagus. So I'm going to concentrate on the motility studies. For liquids, you can use technician milk or Indian chloride milk. Solids, there's the famous chicken liver test, mincemeat, eggs, mashed potato, or toast. There's no agreed standard meal or definitions of what is fast or slow, and tends to be different in different institutions. This is liquid emptying. This is from Cambridge, and the green line is the individual patient, and the blue and red lines are meant to be the upper and lower limits of normal. And you can see in this case that the liquid just drains very rapidly out of the stomach. So this is a fast gastric emptying. For solids, there's the famous chicken liver diet. Now, this was invented in the 50s and involved taking a chicken, live chicken, and this carried on really into the early 80s, and you would inject sulfur colloid into the chicken. You'd wait about 15 minutes, and then you kill the chicken, and then you take out the liver, you cook the liver, and then maybe with a bit of peri-peri sauce, you feed it to the patient. This was very popular amongst radiopharmacy staff, because at the end, 24 hours later, after it had been put in the fridge or freezer, they got a free chicken that they could eat. However, we're not allowed to keep chickens anymore in most hospitals, so people move to other methods. There's very nice mashed potato, instant mashed potato you can use. So what can I eat? Well, as you know, one of the things about eating is that it has cultural and religious norms. So let's take some of the most common meals: mince, eggs, chicken liver, or mashed potato. This is not to do with personal preference, but most people who say they're Christian can eat all of them. Jewish people can eat mince as long as it's kosher, not pork. The same with chicken livers. Eggs, sometimes days they can't eat eggs, depends if it's a special feast day. If you're Hindu, then you can't eat mince or chicken livers. Maybe some eggs, some Hindus do, some don't. Mashed potato is fine. If you're Muslim, then obviously not pork, it has to be halal. Same with chicken livers. But of course, if it's Ramadan, there's no point asking somebody who's a devout Muslim to come up to the department for a gastric emptying study, because they can't unless you want to work before sunrise or after sunset. And then there's your typical patient who will only eat mince, saying it's horrible, eggs are disgusting, chicken liver is not likely, and mashed potato only at gunpoint. So this is one of the problems. The thing is, there's no real normal. There's great variations, not just between people, but within individuals. If you gastric emptying 3 or 4 times on the same individual, you can get, with the same meal, you can get different results. It also seems to get different results at different times of the day. So we always try and do the test at the same time of the day, i.e. start in the morning. Liquid is clearly faster than solids. The half time for should be around about 5 to 30 minutes. Solids, 14, 15 minutes is quite common. If it's slow, then you get gastroparesis, and if it's fast, you get this condition called dumping. The symptoms are very similar. So this is a barium swallow of a patient with diabetes, and you can see that the barium is held up in the top of the stomach and a little bit at the pylorus. And this is a gastric emptying over of the same patient, and you can see you get very much the same pattern with very poor what we call progression of the meal through the stomach. And the time activity curves almost are the curves for the physical decay of the isotope, because when we worked out the half-life of the activity in the stomach is 110 minutes, and if you think that technicians is 6 hours, it's not far. It's a third of that is probably just the decay for the technician. There is an agreed meal between the Society of Nuclear Medicine and the American Gastrointestinal Association. It is SNM, not SNMI, because when these guidelines were written, it was written by the SNM. Can you buy frozen chicken livers? No, it doesn't work. If you've got to actually inject the stuff into a live chicken, so it gets taken up in the live chicken liver, and then you've got to cook the liver. It doesn't work if the chicken's dead, because you need the blood circulation to take the colon. That's why you needed to have a live chicken in your department. It's a good idea though, but sadly no. You just have to have enjoy your chicken livers with peri-peri sauce. That's the best thing to do in South Africa. Okay, so as a standard meal is meant to be 2 slices of toast, 50 grams of strawberry jam, and an egg white omelette. I don't know if any of you had an egg white omelette. It's disgusting. You image at 1, 2, 3, and 4 hours, and there are defined normals, but the range is very wide. So this is a study in a patient, and you can see here that this is the percentage emptied, and this is the normal range. So at 1 hour, this person has emptied 8%, and the normal range is 10 to 70%. That's a very wide normal range. At 2 hours, it's 47%, and the range is 40 to 70%. And at 3 hours, it's 99%. Normal range being 70 to 100. So overall, it's normal, but there is a bit of a slow start. So this patient probably has a little bit of dysmotility. Let's take a little side turning up to biliary disease. And the most important one is biliary atresia versus Gilbert. That's pediatric, so we'll probably discuss that. I think we're doing that tomorrow. Cholecystitis, gallbladder dysfunction. These can be tested by HIDers, and again, obviously, FDG in tumours. So acute cholecystitis, HIDers are a simple test. The cystic duct gets blocked because of the edema from the inflammation. So basically, when you inject a tracer, it goes down through the small biliary tract into the small bowel, but you don't see the gallbladder. Now, it is quite important to ask the patient if they have a gallbladder, because these days with laparoscopic gallbladder cholecystectomy, it's not impossible for a patient to have no real big scarring and have had their gallbladder out. And there's nothing that makes you look more foolish than reporting the patient has got cholecystitis, when in fact what they've got is basically a cholecystectomy. So just be careful you ask them that. We've got another chat thing coming up. It's not the chicken livers again. Ah, right, okay, yeah, okay, good comment. So if you use a 3rd generation HIDer, such as Tribrida or Iodida, and they're the only ones you can buy at the moment, if you don't see the gallbladder by 60 minutes, then it's a positive test and the patient has cholecystitis. In the old days, you had to give morphine or CCK. Now, there is no CCK I think you can buy now. There was some a few years ago, but it's made from pigs and all sorts of problems with swine flu. And lots of people refuse to take it because it contained pig CCK. So it's no longer made. And morphine is not something that you want to be giving to people without good reason. So we tend to use the tribride known as mebrafenin or iodida. So it's such a good test. Why don't we do 10 a day? Well, in fact, in some countries like the US, they still do 10 a day. And in the US, it's considered that you shouldn't really do a cholecystectomy without a positive HIDA. But you really need to be set up to do the test. And one of the problems is you need to have a gamma camera that you can put a patient on at very short notice for an hour, really, to get the test done. Now, the patients do need to have fasted for 4 to 8 hours. If you go beyond 8 hours, you can get a false positive because the gallbladder collapses. So you're trying to fit this in for a study the same day or next day. And then you run into the problem of surgeons. So surgeons are very impatient people. So if you say, I can do you it's now 4 o'clock in the afternoon, the patient had lunch. I can't start this till tomorrow morning, but can you fast the patient overnight? The surgeon just says, I can't be bothered with this, and they'll just take the patient to theatre. However, it is very good, and Fink Bennett in the US demonstrated the sensitivity was 90% compared to just 67% with ultrasound. So this is a nice study from the 1980s. I don't suppose many of you remember that were around in the 80s. This is just when I started nuclear medicine. And you get here good uptake into the liver of the tracer, and then activity passes into the small bowel and continues to drain. This is over an hour, but what you don't see is any activity in the gallbladder. This is a slightly more modern study, but it basically shows exactly the same thing. These are 1-minute frames, and you can see the number. It goes up to 58 minutes here. And you can see uptake within the liver, parenchyma, then drainage into the biliary system, slightly better resolution with flow into the small bowel. A little bit of hold up in the common bile duct there. So the patient may have passed a small stone, but there's no evidence of anything in the gallbladder. So this would be, again, defined as acute cholecystitis. You can find other things with this, and there are some interesting ones. So, for example, in patients who have bile refluxing into their stomach, the stomach is designed to withstand acid, but cannot work with alkaline, which is why things like caustic soda are so dangerous if people swallow it. So what can happen is if you get bile in your stomach, it really, really hurts. So here you have a HIDA. It looks okay. This is 24 minutes. And then at 36 minutes, this activity appears up here. Now, this is not small bowel. This is the stomach. And so what's happening is that there's maybe a stenosis or something near the duodenum, and you're getting backflow of the bile into the stomach. So that's and that would be the cause of pain, quite significant pain. Cholangitis can occur either post-infection and is more common in patients who, for example, HIV positive, or it can be spontaneous, which is primary sclerosing cholangitis. And you get these sort of like beads of HIDA seen in the biliary tract on the HIDA scan. And often, here, as you see here, you get parenchymal retention on one side, but not on the other, what's known as differential flow. And this is a 1-hour image of a patient who's got a cholangitis. We can do HIDAs post-liver transplant, but one of the things you have to remember with the patient who's had a liver transplant is they do not have a gallbladder. So they don't need to be prepped in the same way. So they don't need to have a fast. Now, many of these patients aren't eating anyway because they're just post-operative, but if they're not, don't worry about fasting the patient because you don't need to. But what you may need to do is a late picture. So you may not want to start it at the end of the day so you get a late picture in. There are 3 things that can happen in a transplanted liver: rejection, leak, or where they sew the duct from the transplant liver onto the patient's own common bile duct and get a stenosis there. So again, people have looked at this and shown that post-operative HIDA can be very helpful certainly compared to ERCP. So this is a patient who has had a transplant, and a couple of things that you notice. The first thing you notice is you don't see the small bowel. Okay, it doesn't appear at all. And the second thing you notice is you see this activity here. Now remember, the patient's lying flat down on their back. So what's happening is that probably there's been two things happened. There's been a blockage in the common bile duct, and then there's been a leak. And in fact, the leak is coming out the end of the donor liver common bile duct, cystic duct. What they do is they take the gallbladder off, prevent infection, and they sew up the cystic duct. It looks like here the stitch has slipped, so the bile is coming out of the cystic duct hole and rolling around the back of the liver. So that's going along the back of the diaphragm there. So that's a leak. If you don't see a leak early on, you can do late pictures as well, just like you do with kidney. Okay, just a little bit about pancreas. This is an FDG carcinoma of the pancreas. We're going to discuss FDG imaging a little bit more tomorrow. We've got to the small bowel. Wow. We're going to absorb some stuff now. So what can happen to the small bowel? Well, we can get Meckel's diverticulum. They're very common, but we get it with ectopic gastric mucosa and cause problems. GI bleeding studies, absorption problems. We can get tumours like carcinoid. Again, we'll look at that tomorrow. And inflammatory bowel disease as well. So for inflammatory bowel disease, we'll look at first. So we can use salivary. We prefer, oh, sorry, this is a leak, not inflammatory bowel disease. So this is the salivary for leak. You can use an in vivo method, but that can lead to quite a lot of stomach uptake from patentate, which could sort of spoil your picture. So a lot of people use this semi-in vitro method, which is very simple. You take 10 mils of blood into a syringe with just 500 units of sodium heparin, no more because it won't label otherwise. Then you incubate that with stannous for 30 minutes. Okay, so the heparin stops it from clotting. You seal the syringe up. You then incubate it with stannous. You add patentate, and then you wait another 5 minutes, and then you inject into the patient. And if we do that, you get very, very good labeling, much better than a mugger, so you don't see any stomach uptake. You take pictures over 60 minutes. Bleeding is intermittent, so it may appear and disappear. If the blood enters the gut, then it tends to go in one direction. So remember, it's a unidirectional system. So you may see like a comet tail effect of a bleeding point and then activity moving down the gut. And it can be anywhere from the stomach to the anus, even if the endoscopy has been negative. So here we have uptake, a bleeding study, and if you look very carefully later on, you see this is a spot that appears. So it's just here, it's just on the hour this spot appears. That's in the cecum. Now later on, the blood moves very rapidly in the cecum. It actually goes around to the sigmoid, which is here, but this is still the bleeding point in the cecum. But did you know we had to wait nearly an hour to see that? So it's always worth continuing imaging for at least an hour. Fortunately, we were just got a little bit of flush here, so that's why we continued beyond the hour and found the more precise bleeding point. And the other thing is that you want to be bleeding around about 500 mils of blood every 24 hours minimum to be able to pick this up. What about, I'm going to talk about Meckel's tomorrow with pediatrics. What about absorption tests? Well, they're not commonly needed, but they can be useful. And really one that has the useful one is selenium-75 CCAT for bile duct malabsorption. And this can cause chronic diarrhea, particularly if patients have any ingestion of fat in their food. They can get quite significant and troublesome diarrhea. And what you're trying to do is that you're trying to see whether or not a radio-labeled, effectively, bile acid will recirculate. So you give 400 megabecquerels of selenium cholesterol. You compare that against the standard, and you image the abdomen either in a counter or you can use a Gower camera. The best way to do it is with the collimators removed, with a 250 keV windows, and a keV window, and 50% window. So you're using it as a big counter. You take the collimators off because it improves the sensitivity. The system will then be very sensitive to interference and other radioactivity. So if you have a SPECT CT room, it's best to use that because the lead shielding in the walls for the CT will help to shield your patient. And we also tend to do them fairly early before we start having a lot of patients around the department with high activity injections. In 2019, new criteria for reporting CCATs were produced, and we're now told that this is an improvement. I'm not sure that's true, but anyway, this is what we're meant to do. So you're looking at the 7-day retention. If it's less than 5%, it's considered abnormal. 5 to 10% is considered probably abnormal. 10 to 15% is I haven't got a clue. 15 to 20% is probably normal, and greater than 20% is normal. So what do you do? Probably abnormal. It's a bit useless, isn't it? But anyway, this is what we now are meant to report with. Well, we're moving rapidly down to the colon. For those of you who haven't had lunch, you know, not too much longer before you exercise your own GI tract. For bowel transit, we're a bit limited because in reality, the only way we can get to the large bowel is from the top end. Remember, it's unidirectional. So even if we had access to the sigmoid colon, it's not terribly sensible to put anything in that end because it's just gonna go back out again. So you need to start at the top end, and that means you need a long-lived radio label. So most people use indium. And what you then do is you scan every hour for 6 hours and then 24 hours until these pass the rectum. And you should see activity in the cecum at 6 hours, and it should clear the bowel by 24 to 48 hours. And again, just make sure the patient hasn't had a colectomy. We have had patients who've been sent to us because they have colonic transit problems, and the reason they have a colonic transit problem is a surgeon had taken the colon out. And they just plugged the cecum onto the rectum. But this is a severe ulcerative colitis. And they said, oh, well, if patient's got diarrhea, they must have fast colonic transit. Well, they did, because they didn't have any transit at all, because there was no colon. This is a 48-hour image. And again, there's a lot of variation. Some people will clear their colons in 24 hours. And some people will clear their colons in 72 hours. And to be honest, you probably know how long your colon takes to empty, because you know what goes in the top end and you know what comes out the bottom end, and you can work out the transit time between the two. My personal favorite, if you want to check it, is sweet corn. So, in summary, we can use nuclear medicine in the GI tract, primarily looking at motility. It's more quantifiable than radiological techniques. It offers a low radiation dose, but the tests may take several days, particularly with the colonic transits. And sometimes there's an argument over what's normal or abnormal. They are fairly easy to do. They don't require fancy equipment, and they're probably underused. And that is it. Okay. I'll stop sharing.